Welcome to the Ohio Medical Billing webinar. I'm your host, Ashley Maines Espinosa, an Ohio Northern Pharmacy grad. I'm VP of Clinical Operations at DocStation, a software company who helps pharmacies get paid for services through our platform and medical billing module. As I mentioned, I'll be moderating today's presentation. I'd like to cover some housekeeping items, then introduce my fellow speakers. First, let me turn on my video, which I have to do by unsharing. Hi. There we are. Our three important housekeeping items are: first, please remain muted until the end when we have an open Q&A session. Feel free to use the chat for any questions in the meantime. In regards to the chat, I'm joined by my DocStation colleague, Rachel Matz, DocStation's head of customer success. Rachel is our resident enrollment and credentialing specialist, which is among many of her talents. And she's been connected to a few pharmacies already in Ohio who participated in phase 1 as a pharmacy provider, as provider status has been rolled out. And Rachel will be moderating our chat today during the presentation. Please submit your questions to Rachel. When you submit something to the chat, you'll have a choice of submitting to one of the hosts and co-hosts. You'll see Rachel's selection on there. Because of me presenting my screen and our other speakers talking, we may not see it in time, so please submit to Rachel. The third thing is we are recording this. You'll have gotten that notice right when you logged in, and we can make this available to you if you feel like you've missed something. Just reply to your original invitation with any follow-up questions or requests for that recording. Okay, I'm joined today by Jackie Boyle and Stu Beatty, both who are experts in this field and highly respected leaders in Colorado. Both Jackie and Stu I had heard of before I actually ever met them. The first time I heard Stu's name was at OPA, an Ohio Pharmacists Association annual meeting, when he won an award. And Jackie's name when I was at an OSHP, the Ohio Society of Health System Pharmacists annual meeting, when she was recognized as president of the society. So they're celebrities to me, and I'm so excited to be collaborating with them and working with them in my home state of Ohio for this webinar today. Stu, I'll turn it over to you to introduce yourself. Then we'll turn it over to Jackie, who will also take us right into our goals for today's webinar conversation.
Yeah, thanks, Ashley, and thanks so much for having me. So for those that don't know me, I'm Stu Beatty. I'm here in Ohio. I'm faculty in Ohio at the College of Pharmacy. And I also am doing some work with the state association. So I've been involved in provider status implementation since it's been getting started here in Ohio, worked with some individual pharmacies, talked with the different payers, talk with different vendors such as DocStation, as we're all trying to move this whole thing forward so that our pharmacists can get paid for what we do best, which is take care of our patients. So that's just a little bit about me, and I'll turn it over to Jackie.
Well, thanks so much, Stu, and I feel also honored to be with these two esteemed colleagues on this effort. This obviously takes a village to implement clinical service and provider status. My day job is a faculty member at Northeast Ohio Medical University. My background is in ambulatory care in a bunch of different settings, both building and setting up billing services for those practices, which for any of you who are in the middle of that or are thinking of jumping in or have done it yourself, you know it's not exactly straightforward, and there's lots of steps in that process. So we hope to provide you with some real practical tips today for how to implement these services. So let's just jump right in. So by the end of today, we hope that we can briefly review our path in Ohio in case you are from other states and you're looking to walk down this path. We want to let you know how we got there, which was also, we looked to other states for their guidance because we weren't the first and we won't be the last to implement provider status or creating more sustainable services. We will then also list what billing opportunities are available in Ohio at the moment, and also briefly mentioned federal opportunities that you may be able to get involved with as a pharmacist, regardless of what state that you're in. We'll mention a few of the key successes that we've had in Ohio and highlight a few of the champions who have taken this forward and been successful in billing for their services. And then finally, because technology is so embedded in everything that we do, and being efficient with our time is also really important as pharmacists. So we want to provide you with at least one tool and one platform that you might consider as you're thinking about implementing services yourself. So moving on, before we jump into all of the technicalities, and we know that the title of this presentation is Show Me the Money, and we almost showed a clip from Jerry Maguire to just drive that point home, that we do need to get paid to provide services to be sustainable. But really, we wanted to focus on why we're doing this. And primarily, the why for me is that we can expand access to patient care by providing and setting up sustainable services. Pharmacists have so much value to bring to the table. And I know that, having experienced it myself and working alongside colleagues like yourself, that oftentimes that is not a clear path forward, and it's a little bit tricky to figure out how to set up something that's not only good for patient care, but is provided in a sustainable manner. So I hope that we can provide that piece of this to our webinar today. And I'll turn to my colleagues for you to hear a little bit about their whys as well.
Am I up?
Sure.
Okay. Yeah. So I think my why is similar. Like feel like I've been living and breathing provider status here in Ohio and talking across the country even. So that really is the why, as far as why I'm doing this. I wholeheartedly believe in what we can do as pharmacists to help take care of our patients better. And we have to have the incentive to be able to do that. And the current model does not have that incentive in place. And provider status is a big step in that direction. So I'm actually in clinic today. I still take care of patients. That's why it looks like I'm in a clinic room, because I am. And that's really why I see it firsthand with the patients I take care of, and working with that team, and then trying to get that out to the state level, and trying to get all of the pharmacists that incentive to really care for patients in the way that we should be doing anyway, in the way that we're trained.
For me, it's a bit about the recognition for our entire profession, that we have other mid-level providers that have been able to achieve this. I know we can do it too. I know we can do it better. And coming from a family who ran an independent pharmacy in our community growing up, I think about those who are like us, where it's been the joy of my career to pivot into this space, to support not just a pharmacy, or like when I was working in health systems, to empower a number of pharmacies, but across the nation. And my only biggest fear is that we don't get to people in time, or that state provider status legislation, or in our lifetime, federal provider status legislation would be able to provide those alternative revenue sources because of the other things that are going on with the world of PBMs and slim margins and dispensing.
Well, thank you both. I know we've all been on a lot of webinars lately, so you might have already tuned out, started checking email, but we're going to pull it back in with some polling questions here. I'm going to launch our first two in a moment here. You should have two questions in front of you. First, we want to know, do you practice in Ohio? Yes, no, or you're in a close state nearby. And then secondarily, what area of practice do you primarily represent? Some of you might have your hands in a few different areas of pharmacy, but where primarily are you tuning in from? All right, we've got a good amount of responses coming in here. This is really cool. All right, folks are slowing down. I'm going to end the poll here so we can share the results. So as you can see, most folks are tuning in from Ohio, but we do have a good group, about 30% coming in from other areas of the country or nearby states. And we've got a good mix of folks from all areas of practice tuned in. So thank you all for joining us. It's cool to see the distribution of different areas of practice and the country on our call today. Thank you. So here's our path in Ohio, and this makes it look so simple, but it really was very difficult. Lots of folks involved, The journey starts way even before 2015, but 2015, I think, was one of the landmark more recent legislative wins where we were able to simplify our collaborative practice agreement laws in that prior to 2015, a pharmacist had to have an individual agreement with one patient and one physician. And so the paperwork that was involved with all of that was just tremendously difficult to keep up with. The great thing that came out of 2015 is now one or more pharmacists can collaborate with one or more physicians and take care of any patients that they deem under their care. So it's simplified and eliminated so much unnecessary paperwork for us as far as how we administer our collaborative practice agreements in Ohio. If you're in another state and your laws are very cumbersome like that, please reach out and hopefully we can help you move towards a more streamlined process. Then 2019 was another landmark for us. Yay, we finally got recognized as healthcare providers in the state of Ohio. I always drive this point home to my learners that you should look at the list of providers, especially at the federal level. Everyone else is on the list, but pharmacists were not yet. So thankfully, we became recognized as providers through Senate Bill 265 and a small army of folks working on this with Stu obviously being one of the great leaders who led us through that process and got it passed, which was awesome. In 2020, we then expanded collaborative practice agreements. So now pharmacists can collaborate with other mid-level providers like nurse practitioners and physician assistants, ultimately still under the care of a physician. But it's opened up the doors for us to access CPAs a bit more now since 2020. You'll see underneath this whole timeline, PBM reform was a catalyst in really helping us move a lot of legislative issues forward. And that journey started very early in 2017, 2018. We really started highlighting PBM issues in Ohio, and the reform of PBMs has led to a lot of our legislative wins as well. So that was happening in parallel. It wasn't just some of these landmark bills that got passed too. So as a result of provider status, what we can now do in Ohio is coming up on this next slide. So we're going to bookmark one slide for future use because I know there's a lot of information here. This one might be one to screenshot or take note of because these are the things that we can do now through the medical side of the benefit. So I'm going to reiterate that point a few times that these codes are to be used in the medical side of the benefit. This is not going through your dispensing software. This has to be done through the medical side. And so if you're in a health system, easy or easier, I should say, you have access to an electronic medical record. You can have this billing happen through your EHR. However, in the outpatient setting, if you're in a community pharmacy, you're going to need a software solution to be able to have these claims processed. So that's something to think about, is that these are medical codes, they're medical billing, and you will have to have a solution in order to do that if you can't do it at your health system or if you're in an outpatient setting. So let's briefly touch on the codes on the right of your screen specifically. I wanted to dive into all of the number soup that you see here on the screen and just talk about what these appointments might look like if you're thinking of conducting them, or maybe you're already conducting them, but you're just not getting paid for them at the beginning. So 99211 through 99213 and 99202 through 99203, these are evaluation and management visits. So what does this look like in patient care? Well, these appointments are for patient counseling and education for patients who have chronic disease states, which are likely most of the patients you're taking care of. You have to have documentation in these visits that your services are necessary. You need to summarize the encounter and list a problem list, have a follow-up plan for your patients, and then also make note of the time that you spent in counseling and care coordination. So between 99211, 99212, and 99213, there's a 5, 10, and 20 to 29 minute documentation that is needed for those visits. For the new visits, 99202 and 99203, The 99202s are 15 to 29 minutes, and then 99203s are 30 to 44 minutes. Telehealth codes that you see below those E&M codes, these are essentially those E&M visits, but conducted by telephone. So 99411 through 99443. These are 5 to 10, 11 to 20, and 21 to 30 minute visits of those evaluation and management services that are mentioned above. So if you're having encounters on the telephone with patients, you can bill for that as well. If we move down to G2012, this is a brief check-in or a brief communication virtually with a patient. This is for evaluation and management type visits as well. So 5 to 10 minutes of medical discussion with your patient about their chronic disease state via a virtual check-in can be billed for too. And then you'll see there's a whole host of drug administration codes that fall underneath that. 990 or 90460. Gosh, there's so many numbers here, but this is immunization administration with counseling. And then you'll see the series of 90471 through 90474. This is immunization without counseling. So if you're giving one or more immunizations in different routes, you would use that series of codes. And then finally, 96372. This is an injection of a sub-Q or IM medication. So, so much to take in here. There's more to come, most likely. You know, this is where we're getting started, but there's likely more that we can do. You can see that on the left side of the screen as well, there are some independent services that you can provide and bill for. But any of the things that you're doing with a patient where you are managing their drug therapy, you're increasing a dose of medication, decreasing, discontinuing, this would require a collaborative practice agreement. So that is an important fact to keep in mind, that you will need a CPA for those medication management services. Now, not to overwhelm everyone, but we're going to do this for 1 second. And no, I'm not going to review all of these different codes you see on the screen. We would be here for several hours if that were the case. But I did want to include this slide for completeness sake. And just to note that the codes that are on this screen are available at the federal level, and there are many different rules that are associated with each of them. So some of them you need supervision of a physician, some of them the pharmacist can only be involved in part of the visit and not the entire visit. Some of it depends on what MAC you're working under. So there's a lot of caveats to each of these billing codes, but just know that there are pharmacists who are in teams with providers that are successfully building their practices or running their practices completely based on other billing codes that are out there in the world. But for Medicaid, you got to go back to slide 7 in Ohio. This is the previous slide is the slide that you can bill independently in those scenarios, with the caveat of needing a CPA for drug therapy. So Stu, did you want to jump in on this?
Yeah, I had just a couple things to point out. So thanks for that overview. This stuff's so complicated. Could you go back to the previous slide just real quick, Ashley? So a couple things to point out, and you did mention this, Jackie, but just to highlight that 99202 and 203, that is for a new patient. So that would be the first time you see that patient under whatever tax ID you're at. You can only bill that one time, and then every subsequent visit would be the 9921 through 9921, 11 through 13 for an established patient. So that goes again for any provider. They can only bill that code one time for that new patient. And then the other thing I wanted to quickly point out, under the telehealth, if you look at the Medicaid rules, they did say pharmacists can bill 99441 through 99443, and that's what's written in the rules. They subsequently have come out and they don't pay a 99443 for any provider. So Medicaid does not reimburse that code. So you could still bill that code. What we usually tell people is change that or bill the 99442, even if you're over that time requirement, and you could bill that 443. And Ohio Medicaid, that will not be reimbursed. So hopefully that's clear and not more confusing. I just wanted to clarify those couple of things. Otherwise, great job going through codes.
Yeah, thank you so much for those clarifications. All right, let's go back to one more set of live polling questions here. Here we go. So because this is so complicated as far as billing goes, we want to know, would you be interested in more information about this going forward? As we were preparing this presentation, we thought, gosh, there's just so much to talk about here and not enough time in the day. So would it be helpful to provide more education in the future?
For those folks who are maybes, I imagine that the answer is, it depends. Go ahead and drop in the chat over to Rachel, and not anything that we would need to address, but we'll be interested in some of those considerations on what you're looking for. This is another great time to just go through housekeeping. If you did not catch us in the beginning, remember to keep yourself on mute. Remember to use the chat for your questions until the Q&A, and that Rachel Matz, who you can see on your screen and is a opportunity for you to select as a co-host to message, is your chat moderator for today. So please submit all your questions to Rachel. She will either be able to answer them, save them for Q&A, or direct you that we will answer it at the end. Thank you.
Thanks so much. So it looks like we've got a predominant yes in this direction, and a maybe, as mentioned, which totally makes sense. Thank you all. All right, so moving back to our presentation, we have a little bit of thought about who should get involved. We have community pharmacists online, we have AmCare pharmacists, inpatient, hospital, we've got everybody here, but we think everyone should get involved. Now is the time in Ohio that every pharmacist is eligible to set up services. So it's a great time to be a part of this. It's a great time to take the steps we give you today and start to implement those. And there's still unknowns, don't get us wrong, there's still things that are changing and evolving, but you can be a part of that change and evolution as well. So I'm going to turn it over to my colleague Ashley to talk about some of the early wins that we've seen in Ohio.
So what we've learned from those who've participated already in phase 1 of activating pharmacist provider status is, first, policy and rulemaking matters. If you're joining from another state and are involved in this process, your involvement is crucial to help implement policy that makes sense for pharmacy practice. It's not just the black and white language of the bill. Sometimes it's engagement with a payer to prevent certain things that would make your life harder. So that's not on this slide, but I think that the overarching experience is there are some wins and challenges defined by the requirements. So for early participants, the wins we saw from early adopters, first, the fact that they got to participate. These pharmacies were selected for their participation. That's a win for them. Second, their reach and care capability was able to be expanded through this participation. These primary care-like encounters with patients weren't always just a one-time thing. Repeated care, as we know, creates continuity and maybe the only path where somebody is able to get synchronous care. Some of the challenges, and these are just like really quick ones here and not comprehensive. Some of the challenges were notable. Patients' lists came on a spreadsheet. So pharmacies had some administrative work to do even before they started caring for patients, somehow sorting through the rows and the data to determine who am I going to work on first, who am I going to reach out to, what's my plan of attack. That takes time. And so if you are dedicating a pharmacist or part of a pharmacist day to do this, it may take minutes, hours to create that list of that plan of attack. Then once care has been provided, there was a time and administrative element to log into each payer's separate portal to document and submit that. Stu, I'd like to invite you to share more about early experiences in Ohio.
Yeah, thanks, Ashley. So what happened in Ohio when we first started, once we had provider status that was passed, as Ashley mentioned, we had 4 of our 5 Medicaid managed care plans actually come, and they worked with the state association, and they on their own identified pharmacies to kind of start moving this direction of start paying pharmacists. So this was in really throughout kind of the summer and late 2020. And again, I think it's important to note this was before there were any finalized rules. So this was the MCOs coming and saying, this is how we want to do this because we don't have any rules set yet. When they selected across those plans, They did select some independent community pharmacies. That was the highest number, but they also selected some FQHCs and they selected a health system. So I think it was really good that they chose all of those, because obviously as pharmacists, we practice in all of those, and there's different benefits and challenges and things that may come up in all of those settings. So we got to learn a little bit about what was going on there. And then throughout that process, the other thing that they did across those MCOs is they all had a little bit of a different niche as far as what they were doing. Some of those actually said to the pharmacist, like, here's the disease states that we want you to take care of. There were some other plans that just said, you know what, we think they are your patients. We are trusting you as pharmacists to do what you need to do to take care of those patients the right way. So some of them were really allowed the pharmacist to be able to jump in and do whatever. Not all of them required collaborative practice agreements as well. And we talked a little bit about collaborative practice agreements and some of the changes in the law that were made. Collaborative practice agreements are really, really important. There isn't anything in the law, or I should say, along the codes that say you have to use the collaborative practice agreement to bill for that. So that is a rule that was set forth by the state. And there's people from other states in here that may or may not have that involved. So I do want to note that early on, some of these plans said we do not require a collaborative practice agreement. So after that, since there were already plans and they're already figuring out how to bill, in January of 21, again, all this is during COVID, obviously, the Department of Medicaid did actually finalize the rules. So since January of 21, any licensed pharmacist in the state can participate if those requirements are fulfilled. And those requirements are, for the most part, you have to be a practicing pharmacist in the state of Ohio. So that's really the only credential. Beyond that, you have to have a written order, and you do have to be practicing under collaborative practice, as Ashley mentioned. So that's kind of where things stand since 2021. Some of those pharmacies and pharmacists have continued on. A lot of our pharmacists in the FQHC and in the health system world have picked this up quickly because they do have the ability to have collaborative practice. They can kind of submit those bills on the medical side of the benefit pretty easily. It's been a little bit harder in the community. We have had some success in the community as we've moved forward since 21, but that collaborative practice requirement is really a great limiting step for a lot of them. So we're trying to work with the Department of Medicaid to kind of hone in on what are some of these. We have provider status, but it's not fully implemented, and we have some challenges because of that access point that the collaborative practice agreement is putting in place. So we're continuing to work with them to see if we can kind of get those rules modified. I did want to mention quickly what happened in October. In October, we did transition in the state to the single PBM, which is Gainwell. And we're mainly talking on the medical side of the benefit here. The PBM stuff is on the pharmacy side of the benefit. So the only reason we want to bring that up today is to note that is a significant change in pharmacy. That's been a significant uptake from the Department of Medicaid and from all of our community pharmacists out there for everything they've done. So thank you for that. One thing that we've noticed since that has come about is now on the community pharmacy side, everybody that comes in that's a Medicaid, regardless of which managed care plan they're with, they all look like they have a Gainwell card. So you can't tell which of those is a United Healthcare Medicaid, which one of them is Buckeye Health Plan, which one is CareSource, so on and so forth. So that has been a challenge to some of our pharmacists that are trying to do some of our early implementation programs and are trying to figure out how to start, and they actually don't know which managed care plan the patient is a part of, and even some of the incentive programs around vaccines. So again, we're trying to work with the Department of Medicaid on that. They are aware of that issue. We're trying to get that resolved, but did want to mention there's been a lot of effort and time put forth since October since that happened. If you have any questions about any of this stuff that has happened in Ohio, please let me know. I continue to hear from pharmacists around the state that are wanting to implement things, which is really, really exciting. I just got an email last week from a pharmacist in Southeast Ohio who's at an independent pharmacy and actually reached out and is now going into the local physician's office one day a week and billing on the medical side and has a collaborative practice. So those things are still happening. We're encouraged. We love hearing about that stuff. If you have any questions, please reach out.
So for those that are getting started, let's get down to the nuts and bolts. This webinar said if you're getting into the billing game. So if you're at that point, you've come to the right place. If you're just getting into this, we want to be able to start from the beginning. And some of those finer points that Stu shared, that Jackie shared, those details, those are all some of the background things that you need to know. I've got a list of the 5 top line things that you'll need to do. And if I were one of my favorite educators, Other than Jackie, who's on this, and Karen Kier, who's also on this webinar. You're my favorite too. There's a gentleman named Johnny Sullivan. So this is sort of an inside joke to Ohioans. Put a star on this slide. That like rings in my head all the time. I'm going to do you one better. DocStation put together an Ohio medical billing guide that has all of these steps in it. And it's got website links and other details that you need. And I'll ask another pharmacist member of my team, Max, who is on, who you heard from in the chat a little bit earlier, to drop that in the chat now. So that is a PDF that you'll have at your disposal. Special note that we've separated these things, but since the transition to that single PBM back in October of 22 that Stu just mentioned, a number of these steps should combine. Thank you, Max. I see that is in the chat now, so everyone can access that. I'll remind you all on that. Going through these, we'll go through some more details in this in a later slide, but this is just top line. Here's what you got to do starts with an NPI number. That's that national provider identifier. Individual pharmacists need one of these too. Enrolling to be able to have the state of Ohio's state Medicaid agency recognize somebody who's going to be submitting claims. Who is this person? Are they eligible to be doing this? That's what each of our other provider colleagues are required to do. Then there's, this is what should be combined with some of this single and centralized services with enrolling in the other Medicaid, the Medicaid managed care, more private insurers who take on Medicaid beneficiaries and offer a Medicaid type plan, just going through that detail. And then the credentialing pieces of that as well. And it's really important because of some of the requirements that if you want to do these things, establishing that collaborative practice agreement if it's needed. One more set of polling questions. I've got another poll for you. Wanted to ask another speaker's help to launch that.
Uh-oh, I don't have the launch button anymore. Rachel, do you have it?
No, I'm so sorry. Oh, there it is.
Here we go.
So I'm curious, for those getting into the billing game, do you already have a personal NPI? Be interested in where folks are with this? And then whether you do or not, did your pharmacy participate or did you participate in phase 1 of the Ohio Medicaid Provider Status Program? I imagine that we have some folks who did. But because it was a small program, not everybody. All right, we still got ones coming in. Once I see it slow down, I'll give it about 5 more seconds. Okay, 5 seconds. Looks like many people do. That's excellent. Some don't. That will be your first step. And we know that it's not completely immediate. So we've got somebody who's got that in process. And as you can see for question number 2, we've got some people who did and the majority who didn't. Now, I'll start us off and then going to be hearing from both Stu and Jackie as well on some of these tips and tricks, because it can be easier said than done. I've got your list of 5. And if you think that you would be able to go in and be like, all right, just some afternoon, I'm going to do all 5 of these things. There are some things that you will encounter that these tips and tricks will help. You may benefit also from a partner who can walk you through this. And we're going to invite Stu to talk about his coaching services to do that. But the first thing, this is my favorite. I'm glad that I'm going first here because the NPI part is probably the easiest part. Number 1, it's free. And their website is available again in that medical billing guide. Download that here before this is we exit today's webinar. If you have this as your New Year's resolution to start this process, get going on it, this is going to make you feel good because this part is easy to get to, easy to accomplish. And again, it's free. Jackie and Stu, tell us about some of these other ones.
Yeah, so the next thing, after you get your NPI number, the next thing you're going to have to do is you're going to have to get a Medicaid ID number. This process changed actually on October the 1st as well. So in the great billing guide that the folks at DocStation put out in September, that information now changed in October. So you can still go through that process. We actually, at the Ohio Pharmacists Association, we have gone through that process and have some new screenshots. That's actually been sent off to the Department of Medicaid to make sure that that's good, and we're going to make sure that that's available to everybody. But that's the next thing that you have to do. And once you get into that state Medicaid, you have your Medicaid ID number, you have to enroll with the actual plans. So currently in Ohio, being, what is today, January the whatever, 12th, we still have 5 managed Medicaid plans, which are United Healthcare Community. There's Molina, there's CareSource, Paramount is still there. And I feel like I forgot one. So sorry if Buckeye Health, I think that's the other one I forgot. So I say that because on February the 1st, we're going to add on 3 new plans. So Paramount will no longer be there. We are going to be adding on Anthem, Humana, and AmeriHealth. So when that happens in February, I'm trying to find out right now through this new credentialing process that started in October, if you already are enrolled with those payers, are you automatically going to be enrolled with the new ones? I'm awaiting that. I sent those emails off this week. So I'm hoping to hear back from the department on that. But anyway, you will need to be enrolled with each of those plans to actually bill for services for those patients. So that's a really important one. And then the credentialing tips, that also goes into that for number 3. Those changes are coming on February the 1st when those new plans get added on. And we are trying to get that information as best we can. And we'll be sure to share that across probably multiple venues across Ohio to make sure that pharmacists are aware of that as soon as we get that information. And then Jackie, you want to talk a little bit about CPAs?
Yeah, sure. So CPA, as you can see, is a key component of being able to bill for many services. And you might be thinking that just sounds daunting to create a whole collaborative practice agreement. Well, please know that we have templates available through your associations, through your colleagues who are likely on this call. You likely do not need to invent your own CPA. We have templates and forms that are ready to go. You just have to plug in, your services, your providers, and you're good to get going. Something else that can be considered that I did in my former life is that you can institute institution-wide CPAs in the health system. I know our chief medical officer had a sign off on an institution-wide CPA so that any provider who was interested in collaborating with us would simply put an order in the medical record for a consult, and then boom, they're automatically in our CPA. So that streamlined so many different things, saved so much time. And with that level of support at the top of the administration, you can really simplify things in the health system very easily. So it can be simple, even though it might seem overwhelming at times. But also, as you can see, there's lots of steps to this process. So I want to turn it back over to Stu to talk to you about some resources that might be helpful.
Yeah, thanks, Jackie. So this is the Pharmacist Provider. This is a company that I've recently started. And this is to help train pharmacists who want to do provider status. This is really based off the experience that I've had starting things in clinic, but even more so with provider status and helping other pharmacists the last couple of years here in the state. So there's various modules. It's an online system, so you can take it as you would like. It's asynchronous, so there's no live chat feature or anything to that. But the things you're going to go through are, how do I decide which service to select? Once I've decided that, how am I going to market that to my patients? How do I make sure that I'm meeting those requirements, and how do I document things out? How do I track my outcomes? All of that is going to be in here, as well as additional information. I saw everybody on here wanted more information about the codes. There's going to be more information about billing and what some of those requirements are. So this is what this was put together for. Please take a look at the website. You can see in the screenshot down on the bottom right, as you're going through this training process, there is essentially a document you can open and fill out as you're going. It really is meant to be for adult learners, and it really is meant to be applied as you're learning it. So it's going to tell you, how do I use my technicians in a new way? And you can write all that stuff out. How do I share all this information so my whole staff is on board? That's what the whole thing was designed for. The good thing for all of you is it was not written just by me, and it's not my voice. You don't have to listen to my monotone through all of these. There's actually somebody that has a voiceover over top of all these sessions. So if you're interested in anything with that, please let me know. Please reach out. The whole purpose of this is really to train pharmacists to be able to do this provider status stuff, because this really isn't information that has been in pharmacy curriculum for very long, if at all. Because this is a relatively new process. So that's what that's about. And then I think Ashley and Jackie are going to talk a little bit more about just a couple of resources that are available.
Yeah, some of the questions that you may be asking yourself is, okay, I see I need to do that stuff, but how am I going to do this in my pharmacy? How am I going to do this in my practice? All that Stu just shared, you have a coach that is ready to go to stand by your side to do that. I would say that from the DocStation perspective, many of the questions, almost approaching half of the questions that I get are folks that are asking about workflow integration. What am I going to do? How am I going to do it? And then we can get to actually doing that, on a software after answering those questions. But this is the profession's question at this time. So the statements that we have to share, and Jackie, just jump in here, is a little bit of is there a right answer to who is going to set this up? One of the things that I heard someone say recently, you've heard in your time in our careers, top of the license, right? Well, top of the license sometimes may be using vocabulary that assumes that, well, we just want to put people just doing the top of the license things. But there are administrative pieces. There are things like documentation that no one is too good to do. And we need to work in the scope of the license. And so I've adjusted my vocabulary use rather than just saying top of the license to say the scope of the license, so that we can work across through the entire scope. Jackie, jump in here.
Yeah, I mean, I think all of us have worked through some of those administrative tasks, and I always felt like it helped me understand where to troubleshoot when things were going wrong, or having that experience has helped set up future services. So sometimes you do get in and get your hands dirty on some of the administrative stuff. I know things that have been really helpful for me, and was private chatting with a pharmacist colleague in the chat about having really great connections with your billing and compliance teams can help you implement, as well as your IT staff, if you have IT staff. Again, if you don't have a tech staff, well, we've got some great connections on the line that can help you with that. But it's really an interprofessional effort, and it should be a team effort to get those services implemented. You don't have to be in a silo of your own pharmacy team. So reach out to those resources you have, either internally or externally, because there's plenty of partners who can help you implement this. I think I'm going to turn it back to Ash now for a little view of one technology solution.
Yeah. And that's where workflow comes in. What's this? What might this look like? I wanted to share with you some screenshots of what this can look like, because when working with a vendor partner, you're able to step outside of trying to fill out CMS 1500 forms to bill to the medical benefit, or other types of things that are very administratively burdensome. So let me share that I work for a company called DocStation, and if you're going to build for your services to the medical benefit, I've got bad news that we've already shared with that your pharmacy dispensing system is either not going to get the job done, or it won't submit a claim that optimizes your revenue opportunity. For example, some dispensing systems may bill for a vaccine product, but we really should be billing for the product, the administration, the code of which we shared, and then at least for COVID, the counseling that goes along with it and has payment mandates around it. The next few slides will take us through billing of a vaccine. Just as an example, I want to show you what it can look like on a platform, so that if you were to if you were to go to your pharmacy owner, or say you are the owner, or say you're at a health system, that this is possible and can be integrated into your workflow, as well as something that's easy and a bit slick too. This again is on a platform called DocStation, which is a pharmacy EHR built by pharmacists for pharmacists. And as an EHR, think about EHRs that you've worked with in your career, DocStation has multiple functions and can help you maintain your patient relationships, improve their outcomes, and get paid in the meantime. So at any EHR, we're starting with how we have our patients in here. And these patients have full list of demographic information, their payment information, their medication lists, et cetera. Once a patient has been successfully loaded onto the platform, their patient profile and health record are able to be updated, modified, or other things as needed. This allows you to update them as necessary. For example, if a patient address or their member ID changes because it's the first of the year, you're able to do that. You're also able to, through some integrations that we have, import your pharmacy dispensing software, so you don't have to add all of these in manually. So this is just going to be the medical billing part. We're here in a screenshot of the DocStation platform, and we've clicked on claims and the process to submit a claim. The beauty of that is that regardless of payer, or even if you have your own documentation system outside of DocStation, you can use our system to submit and, more importantly, track all of your claims. So if you just want to get billing to the medical benefit, this is one of those things. So we're going to hit create a claim. And I've typed in here vaccine. As you can see, there's multiple options here, but we're going to pick the Moderna COVID-19 vaccine booster. And so that's a claim template that populates certain things of codes. This is all transparent for you to see what codes are being put in there and where they go. And say there's a new one that comes to market or something like that. We build new ones all the time. So let's get into what that would look like. Here are some of the fields, and you can see many of these are discrete fields. Discrete fields are important for sharing information. If you're going to be reporting on this, if you're going to be integrating, or if you're going to be sharing with, say, your state Medicaid agency. A pharmacist or a pharmacy team member follows the prompts. What's great about this also, throughout a lot of the things through assessments and other types of templates, is that this can also drive workflow to standardize training, as well as standardize your patient's experience, because they're going to have the same type of person ask the same questions in the same order throughout their experience, no matter who they're working with. Each template, as you see with number 2 there, includes a CPT code. If there's any modifiers necessary, diagnosis codes. If you're a 340B entity, we know that modifiers need to be added if you're going to be billing for an actual product. And this is just for a vaccine template, so it may look a bit different if you are working from a different template. Now that I've hit submit, now you want to see what's happening to my claims. Have they gotten paid? Have they been denied? If so, what are those reasons? You can track all of your patient claims using the dashboard here. You can track by claim number, the status, the location. Say you have multiple locations in your health system or your retail pharmacy business. And if you need to upload claims in bulk because you have something else, or need to make reports, we can do that too. I wanted to highlight a couple of other things. As an EHR, or when you're implementing these clinical services, you may need to utilize a software to do some of these other things, and wanted to touch on the fact that there's a couple of other bells and whistles that are really helpful in order to get out there to your patients and get these encounters available in your pharmacy rather than waiting for everybody to walk in your doors. The first one is patient messaging. So you may be employing a whole nother software for this, where you're securely messaging via text message patients. The example here is with Mr. John Bridges. It's asking him to schedule an appointment. So Mr. John Bridges will receive a text, can click on that secure link. It actually takes them into DocStation, where they can look at patient scheduling. So you can create a schedule, make different things, intake, vaccine appointments, other types of appointments, and select what days of the week you're available, the times. You can build that all, that's custom there. So those are just a few bells and whistles I wanted to show before taking us to the last slide I have before Q&A. So get your questions ready, is about reporting. So we're hearing from Medicaid in Ohio that increasingly that they're interested in having data be shared back to them as an agency. And in general, this is growing in importance. Data related to outcomes, to savings. There are example, we have all types of reporting capabilities. So some example ones that we see people ask about all the time are, what are all the interventions that I've run in the last month, in the last whatever, custom dates, or say you're more than one store, you're a pharmacy owner and you're employing your team to do this. What are my people doing if I've got multiple people doing that? The user activity or productivity. And lastly, disease specific efforts. I can think of if Ohio Medicaid ODM wants to have just the stuff on diabetes, being able to do that too. We've got about 10 minutes left. This is perfect timing. And we're going to take you through our key takeaways. So again, get your questions ready. They'll be sent to, please send them to Rachel in the chat and we'll be answering them one by one. And Jackie, go ahead and go through our first one and we'll
sure.
our key takeaways.
Yeah, so some things we hopefully drove home today were, number one, there are so many opportunities to build sustainable services. As you can see, they're somewhat complicated at times, but we're learning a lot and we have tools and resources available for you. So don't feel like you have to go it alone and that this is not something that's unachievable.
Yeah, and I think I'm up next with just, as you've heard, like you're not alone. There's lots of different partners out there. This is a big step for pharmacy, and we recognize that it's really important for all of us, but it's also something that's new and it's something that's kind of a challenge. So we want to encourage you to start doing something today. If that's get your NPI number, if that's starting the process for your Medicaid ID number, just start the process. Look at what some of the different partners are. Talk to some of your different folks at other pharmacies, your buying groups, like whoever that is, try to come together and even kind of form a little community as you kind of go through this path together. One thing we saw with those early implementation things is it really kind of that community network and being able to share ideas and best practices was extremely valuable. Ashley?
And I'm going to invite Max to drop your website in our chat, Stu, because one of the partners could be the Pharmacist Provider, and having a coach to go through that, having education that is that you and or your team are all able to do and go through the same thing. Thanks for putting that in there, Max. And then lastly, leveraging technology solutions can help you maximize those opportunities, whether it's to maximize those billing opportunities, maximize the time that you're going to spend to do that, or otherwise. So as a technology vendor, that's my plug in there. And I'm going to bring us to our Q&A slide. We've got a number of things in here. Rachel, what can we address first?
Yeah, hi everybody. I first want to say thank you so much. I have been busy this entire webinar trying to answer questions as they come in. So this has been great. Hopefully I was able to get to everybody. If not, feel free to keep going in the chat and I'll go through them as I get to them. But there were several that I think would be really great to just address. And, you know, either Stu or Jackie, if y'all can pop in and help answer some of these, I think would be great just for the whole crew to hear. So we did have a couple of questions around whether these codes, E&M codes, the telehealth codes, things like that, can be built in a hospital outpatient setting.
Yeah, I can take that one, or at least start that one. So the rules in Ohio specifically state that you cannot bill as a provider if you are in a hospital or if you're in an emergency department or if you're in an inpatient psychiatric unit. So essentially, if you're at a place that does allow facility fee billing, if you're familiar with what that is, if your clinic happens to be one of those, you cannot bill as a provider. You would still be able to bill that facility fee. And again, without getting too bogged down in that, if you have questions, please follow up with me. We have brought that up, I will say, to the Department of Medicaid. We are aware that that is not consistent. We are aware that, like, as a nurse practitioner, you can bill that facility fee and you can bill as a provider. But as of now, that rule has not changed. However, if you are in one of those settings, it's really, really critical that you find out what type of clinic you're in. So as I mentioned, I'm in clinic today. I'm in a primary care clinic that's affiliated with a large academic institution. My primary care clinic is not considered a facility, but some of our specialty clinics like cardiology and stuff like that are. So even within the same system, they may or may not be considered a facility. So you really need to check with how they have that set up. And that affects reimbursement across the entire clinic, not just for pharmacists. So hopefully that helps.
Thank you. That helped my understanding as well. So I appreciate you answering that. Okay, so we had a couple more questions. Now, obviously, today's conversation was mostly around MCO options here, but I wondered if somebody could speak a little bit about the differences that we see with Medicaid, Medicare, and commercial, and just kind of helping folks understand the differences between those.
I don't know if I fully understand the question, but as far as billing as a provider across the state, in Ohio, we have the ability to bill Medicaid. Because we do not have provider status on the federal level, we cannot bill Medicare patients. On the commercial level, it's really up to that commercial plan. So a commercial plan or a private insurance company, they could reimburse pharmacists. Hopefully on the medical side, using the same process will be easier for us. But that is up to them to include pharmacists in that network. So there are some, I know of some small insurance companies that are reimbursing pharmacists or maybe reimbursing specific pharmacists that are within that system, whatever the case may be. But I'm not aware of any third party that's reimbursing pharmacists on the state level. If that exists, that would be amazing. Please let me know so we can publicize that. But hopefully that kind of helps answer that question, that differentiation. Jackie, I don't know if you want to try to clarify that, or if we think that's good, we can move on maybe. I don't know.
No, I think that's good. I think the one thing to add is that if you're in collaboration with the provider, that's where you can get to some of those other billing opportunities, but you need to be under that provider's NPI.
Perfect. Thank you. That helped answer that question. And we did have another question come in specifically within the long-term care arena, and wondering about maybe just somebody providing a little bit more information on other areas that have been successfully reimbursed for cognitive services within the LTC community.
Yeah, so I've been asked this question before too, and I don't know that I fully have this one figured out yet, but I have tried. So when it comes to long-term care, one thing to note, and this is not true completely across the board, but a lot of long-term care facilities, those are Medicare patients. So automatically you can't bill Medicare. And a lot of those long-term care facilities do have those bundled payments that there does have to be a pharmacist review of medications. So as you're going down the path of if you want to bill as a provider there, I'm still not exactly sure if a long-term care facility is considered a facility within the inpatient billing or if it's not. I don't have great clarity there, which would provide a lot of clarity as far as if you could bill or not. If you wanted to bill Medicaid, I think you would have to be very, very careful in talking to your compliance team that the service you are providing is different than the service that's already provided as part of that bundle payment and as part of that review of those medications. So I know that's like a kind of a generic answer and a quick answer. There's probably a long-term care pharmacist that asks that question. So if you want to reach out and maybe even help educate me and we can help figure that out together, that would be great. But that's kind of in general where things stand with long-term care.
Awesome, thank you. So I have seen different fee schedules for different MCOs, but we did have a question around trying to get exact reimbursement amounts and what that looks like, things like that. Where can folks go to find that information?
I had someone send me that question too.
Yeah, the best place to go is look for the state of Ohio Medicaid physician fee schedule. That gets updated on an annual basis. And there should be a reimbursement for each one, for every code, actually, including those codes pharmacists can bill. And then it's very clear in the rules that pharmacists would get 85% of the reimbursement on that fee schedule, So whatever that payment is, a pharmacist would get 85% of that payment. And that's, again, in line with what a physician's assistant or a nurse practitioner would get. But that does come out. It is a little harder to find than I would think it would be, but it is publicly available. So it is on the Department of Medicaid's website. That's probably the best place to go and find it, because that's where all of those different health plans, Medicaid health plans, are going to base it off of that Medicaid fee schedule.
I had a question that was similar to that, which I can address there. And it said, well, billing is one thing, but getting paid is another thing. And we've addressed, yes, you can bill, but will you get paid? And the answer is, if you have fulfilled all of the requirements for the NPI, the getting enrolled and credentialed, the state is mandating that you do get paid. And so say you get a denial, you would be able to show them Actually, you do have to pay me, and it's at this rate, times 0.85 for that 85% of that. So someone had a question of like, but are you going to get paid? If you've met those criteria and you're submitting it to one of the state fee for service or MCOs, yes, because it is mandated by the state of Ohio.
And Jackie did a great job of actually finding that resource and dropping that in the chat. So I believe the resource you just dropped in there, Jackie, comes directly from the Department of Medicaid and is the most up-to-date fee schedule. So thank you for putting that in there.
We are at the 2:00 hour. And so anybody who wants to stay maybe for another minute or two, hearing maybe a couple of the other questions, we'll do that. And then for the others, if your question has not gotten answered, again, feel free to reach out to sales@docstation.co, which is the email address that directly invited you to this webinar. And thanks for everybody. If you have to head to your next meeting, thanks for your time and joining today. Rachel, any last minute things that you've got burning there?
I did have some more questions. So if Jackie, Stu, Ash, if y'all still have a couple minutes to hang on, I'm sure people would love to know. One specifically regarding telehealth. So I know that there are some other states that are slowly starting to discontinue this for emergency telehealth visits, but is this something that you expect to continue to be an option for folks to be able to continue to provide and get paid for?
Man, that's a great question. If I could predict the future there. So I think my guess is what's going to happen is a lot of telehealth came available and those reimbursement rates actually were pretty good because of COVID, and all of a sudden everybody went to telehealth. And I think now what's happening is you're going to start to see a little bit of like, no, we want to see things face to face, and they may either cut those rates or they may not be as high. But I think the future is access for patients, and I think there's got to be some telehealth options. So I don't think telehealth is going to go away. Those codes that are currently listed, there's lots of other telehealth codes that they continue to come out with for specific digital health products and all the kind of stuff that's there. There's lots of stuff that's there, and I don't think it's going to go away. What the future is going to be, I don't exactly know. And I'm not exactly sure. I don't think it may be likely to be like, okay, Medicaid's not going to pay for this code, but Medicare is, and commercial insurance is going to pay this, or whatever the case may be. I think it's going to be a little bit of a wild, wild west about telehealth over the next 5 years. And then I think we're going to be kind of figured out.
And I think it also goes back to like, are we collecting data to demonstrate positive outcomes? Because if we look at like federal trends with expanding chronic care management services and Medicare realizing that patients need more touch points and more access to care, if we can continue showing that through these new codes, I would hope that they would continue them on and further expand them as we see patients more healthy over time.
Absolutely. Awesome. I don't necessarily have any other super burning questions, but there were a couple of great points made that I did want to share. We talked a little bit about CPAs and, if you're not for commercial plans or things like that, that you're not able to bill direct as a pharmacist. Did want to mention incident to billing, being able, that's kind of the category that you would be looking into, coming to that agreement with the physician, and then being able to bill under that NPI, like Jackie mentioned. So if you're looking for the specific phrase, incident to billing would be the option there to go. And then we did have someone also mentioned, Catherine, I wanted to point this one out, that she has noticed that some commercial payers will mark pharmacists as specialty providers, which could result in higher copays for the patient. So I thought that was something to also bring to the table as well, just for everybody to hear.
Thanks for sharing those last bullet points, Rachel. I'm going to close this out for now. Again, thanks for your time. If you have any other questions or would like the recording of this webinar, please reach out to the email address that sent you the original invite, and go Bucks.
Thanks, everybody. Thanks, Ashley. Thanks, Jackie.